Virtual reality simulation for learning minimally invasive endodontics, a randomized controlled trial by Srakoopun in 2025, groups from Thailand and Germany. With the advancements in digital technologies, virtual reality has emerged as a transformative tool in dental education. The VR offers an immersive and highly realistic learning environment, allowing students to practice procedures in a controlled, repeatable settings. This technology enables trainees to stimulate the complex techniques, such as accessing the dental pulp without the risk of harming actual patients. One of the most valuable features of the VR system is the incorporation of a haptic feedback, which provides users with the physical sensation of drilling through various layers of the tooth. This enhances the realism of the training experience, allowing students to refine their skills in a manner that closely mirrors the real-life dental procedures. The evidence from recent studies suggests that the VR platform effectively supports the skills acquisition by providing haptic feedbacks, three-dimensional visualization, and a safe, repeatable practice environment. Although the studies shows low to moderate evidence and some has some risk of bias, the comparative evaluation have shown that the VR-based training can yield performance outcome comparable to those achieved with the traditional phantom heads model. Despite increasing in the interest in the VR-based training, most existing studies have focused on a conventional endodontic access techniques and relied on subjective evaluation. The application of immersive VR simulation to techniques of the minimally invasive approach, particularly the conservative access cavity technique. The study aims to evaluate the effectiveness of a virtual reality-based simulation platform with automated feedback in teaching minimally invasive access cavity to preclinical dental students. The primary objective was to determine whether the VR training could enhance the student performance in a conservative access cavity by improving the tooth structure preservation as measured by micro-CT. The secondary objective included the evaluation of procedural accessing through the expert-rated error scoring and the assessing efficiency by the task completion time. They hypothesized that the students' training using the VR simulation system would demonstrate superior performance in minimally invasive endodontic access compared to those training using conventional phantom head models. It's a prospective randomized control and blinded trial was conducted with the two types of access cavity, the traditional access and the conservative access. The traditional access cavity involves the complete removal of the pulp chamber roof, followed by direct access to the canal orifices, and the conservative preparation begins at the central fossa of the occlusal surface and continue with the slightly converging the axial walls, preserving part of the pulp chamber roof. Before the training sessions begins, all the participants completed a pre-training assessment with an endotype tooth model embedded in a phantom head, and no performance feedback was provided during or after this initial session. The participants underwent 3 consecutive days of training using either the VR system or the phantom head according to their assigned group, and after the completion of the training session, a assessment was conducted following the same procedures. In the virtual reality training, the VR simulator utilizes in the study used the Unreal Engine, Vivo Pro Eye headset, a combined resolution, and the integrated eye tracking centers. The dental handpieces and mirrors was also provided and operated by the 2 Geomagic Touch haptic devices, providing a 6 degrees of freedom. These devices delivered haptic feedback, simulating the tactile interaction between the handpieces and the virtual tooth, while realistic drill sounds effect was also incorporated. An automated outcome scoring system was developed and validated. So the outcome measures here, the study was a pre-training and post-training control group design, and the main outcome measure was the tooth volume loss using the micro-CT analysis. The pre and the post-preparation scans were aligned using an automated rigid registration to ensure that both databases were in the same spatial orientation, and the differences in the volumes was calculated. The secondary outcome measures, or the procedural errors, were assessed by 2 board-certified endodontic experts blinded to both the trainee and the training status. A 3-point scoring system was used to evaluate the procedural errors across 6 regions: the 4 axial walls and the roof of the pulp chamber and the pulpal floor. The criteria was defined as follows: score 0 as minimally extended cavity, and score 1 slightly under or overextended cavity, and score 2 severely under or overextended cavity, resulting in inadequate retention form. So in the results, a total of 34th year dental students, 15 in each group. Regarding the eyesight, most practitioners reporting having a myopia, with 73% in the phantom head group and 67% in the VR group. Although no statistically significant difference between the groups or genders regarding age and the pre-evaluation tests indicating a well-balanced distribution. In the tooth volume loss, the extent of the tooth volume loss did not differ significantly between both groups, and the types of the access cavity preparation significantly influenced the amount of tooth structure removed. For the procedural error scores, the analysis revealed no significant main effect of the training method or even in the access preparation techniques. In a conclusion, this study supports the feasibility of automated visual reality simulation as a scalpel and effective tool to support student learning and minimally invasive endodontic procedures within the preclinical dental education.